So this is just a brief outline. I'll be talking about if you've got fatty liver disease, what's your risk of dying from your liver disease, and also complications of fatty liver, which include cardiometabolic complications. Just to make it a little interesting, I'll start with a case which also fits quite well into the transplant session. So this is a case of a 61-year-old Italian lady who had had a history of diabetes for just over a decade, only requiring oral hypoglycemics, and she didn't have any particular macro or microvascular complications of her diabetes. But at the time of diagnosis of her diabetes 12 years ago, she was also noted to have mildly abnormal liver tests, and that was followed up with an ultrasound, and she was told that she had a fatty liver. She really drank minimal amounts of alcohol. And I saw actually Osborne Park Hospital just as an open access endoscopy for some gastrointestinal symptoms, and found some esophageal varices, and this is really the first time that she was noted to have any complications related to a liver disease. So started her on some beta blockers and sent her to the clinic. We had a look into her in the clinic, did the usual bloods, and nothing came back. It was a diagnosis of cirrhosis due to non-alcoholic steatohepatitis. She was a child's A at that stage, but had some obvious portal hypertension, and that was also confirmed on an abdominal CT scan. So what did we do? We controlled her metabolic risk factors as best we could with a referral to the endocrinologist, referred her to the dietitian, although she wasn't significantly obese. Continued the beta blocker aid. We tried pioglitazone, as there's some evidence to suggest that that may retard fibrosis progression, but she was intolerant of that, which is fairly common, and then started her on surveillance ultrasounds. Now, during her observation, she actually went up the road to see our colleagues at Royal Perth Hospital after she presented with a variceal bleed from her esophagus, and I think was banded by someone in the audience today. But she was obviously an extremist. It was a difficult test. I'd written failed banding, but I think it was not so much a failed banding, but a post-banding ulcer bleed. And she had to undergo an emergency tip scan. And then at that stage, she was a child's B. She decompensated a little from her variceal bleed and was sent back down to us for consideration of transplant. As she's being worked up for transplant, she actually had some more cross-sectional imaging. It was found to have a small liver cancer. It was just less than 2 centimetres, so that was observed on the wait list, and a few months after activation, she underwent a transplant. Now, unfortunately, she had a fairly torrid time post-operatively with portal vein thromboses, basically body failure, and died very soon after the transplant. So clearly, for this particular individual, her diagnosis of fatty liver did matter. But on the background of that, probably 5 million Australians have fatty liver disease, and probably 1 in 4 of people in this room either have non-alcoholic or alcoholic fatty liver. What is your chance of actually dying from this disease if you have fatty liver? And these 5 million Australians, are you actually going to die from your disease, or do you have an increased risk of dying? So that's my first question to answer today. So this is the sort of one of the first largish cohort studies to try to answer this question, and it came from a county in Minnesota called the Olmsted County. They've got a nice population-based database to allow these kind of studies, and there's 420 individuals who are diagnosed by their general physicians or hospital specialists, and are followed over just over 7.5 years. And when they were compared with the age-matched control population in that state, you could clearly see that there was an increased mortality rate in people who had fatty liver. And the magnitude of that was about 34%. So clearly people with fatty liver disease do have an increased risk of mortality, but is that because of the fatty liver, or is that because of the associated metabolic abnormalities which commonly accompany fatty liver, so obesity, diabetes, hypertension? And this study couldn't answer that, but this study did. And so this is the NHANES cohort, which is a large population-based cohort from America, and in the period of 1988 to 94, they all underwent ultrasounds. Now, the ultrasounds actually look for gallbladder disease, rather than fatty liver, but they retrospectively looked at all their images, hard images, and found out whether they had fatty liver or not, and then followed them over time. And the sum result was that once you adjusted for their obesity, their diabetes, their hypertension, smoking, alcohol, etc., there was no increased risk of death, no increased risk of cardiovascular death, and no increased risk of liver-related death. And so this was a tremendous disappointment to all the researchers in the area of fatty liver disease, because it just sunk why is this an important disease. Now it takes 2 decades for your hepatitis C to start to emerge as a risk factor for liver-related death. And we know fatty liver just clinically is a more indolent disease than hepatitis C. So with just a follow-up of 14.5 years from this study, perhaps this was underpowered to really determine a difference. And there's been a few other criticisms of this study. Clearly ultrasound's not particularly sensitive the larger you get, and for instance only 45% of morbidly obese people in this study had a diagnosis of fatty liver disease, when clearly we know from biopsy studies it should be higher, around the 90% mark, and so that's a group of subjects who are probably at most at risk of mortality from their liver disease not being included in the case definition. But nevertheless this is the best that we have. And so this is a little bit at odds with our clinical experience that some people do actually die from their fatty liver disease, a la the case that I presented. And so what was the next step was people looking for subgroups of people with fatty liver to see whether they are at increased risk. And so these are the groups that people have looked at. And this study is also from the same NHANES data, and it really concentrated on sex and race, and the fat white man is at increased risk of liver-related death from fatty liver according to this study. And so these hazard ratios here for dying from liver disease, if you have a diagnosis of fatty liver, if you're male, or if you're white compared to other ethnicities. But I draw your attention to the very wide confidence intervals here, really casting some doubt about how valid these findings are. So maybe further studies are really needed. How about the metabolic syndrome? And so metabolic syndrome is a combination of factors which revolve around central obesity and its associated problems, hypertension, dyslipidemia, and insulin resistance. And this again looked at the NHANES data and compared if you had a diagnosis of NAFL and you had the metabolic syndrome, or you did not have the metabolic syndrome, what was your outcome? And if you had the metabolic syndrome and you had fatty liver, clearly your outcomes were worse in terms of all-cause mortality, heart disease, as well as liver disease. But again, with the small number of liver deaths, the hazard ratio is obscenely high with very wide confidence interval. This, however, did not answer the question whether it's actually the fatty liver that's the risk factor, and so they did go on to do that analysis as well. And this is asking a different question. It's asking if you have the metabolic syndrome, is the presence or absence of NAFL a significant prognostic factor? And it was. So if you had fatty liver, if you had metabolic syndrome and fatty liver, you did worse compared to if you just had the metabolic syndrome without fatty liver. And again, that's for all-cause mortality, cardiac and liver-specific mortality. So it would seem in this subgroup of patients with metabolic disease, if you have fatty liver disease, your prognosis is worse. The last group, and this from a hepatology point of view makes more sense to us, is that the patients that have more histologically aggressive disease on biopsy that do worse. And so just a quick recap for people in the audience that aren't familiar with the histological spectrum of fatty liver. From one end, there's just benign steatosis, which just means these sort of macrovesicular fat droplets in your liver, but no inflammation or scarring. And when you develop steatohepatitis, that's characterised by liver injury with ballooning and inflammation and inflammatory infiltrate. And that can lead to scarring, which is highlighted in these blue, and that can progress to cirrhosis. So the recognition that it was the histological severity of disease which really defined your outcome was shown in this biopsy study a cohort from Scandinavia where they looked at nearly 130 patients over 13.5 years, and they show that if you had a baseline diagnosis of just bland steatosis, your survival was equivalent to the general population, whereas if you had steatohepatitis, you had a reduced survival. And so they've gone ahead and done the same thing with the NHANES database, except for doing biopsy. They've looked at these non-invasive fibrosis measures called APRI and FIB4, which are based on platelet count and aminotransaminase, and then the NAFL fibrosis score, which is based upon simple blood tests in combination of things like age and diabetes. And you can see that if you had fatty liver and a high advanced fibrosis as defined by these non-invasive parameters, you had an increased mortality rate, an increased cardiovascular mortality rate, but not an increased liver mortality rate, and that was put down to relatively low numbers of liver-related deaths. And this slide just illustrates that it's not just the steatohepatitis, it's actually the scarring in the liver, which probably is the most important factor. And this cohort from Cleveland showed outcomes of patients with biopsy-proven NAFL according to fibrosis stage. And you see if you had F0, F1 or F2 fibrosis, your long-term survival free of liver death or transplant was the same, whereas if you had bridging fibrosis or cirrhosis, clearly your survival was reduced. So are there subgroups of patients with NAFL that are increased risk? Well, yes, there are. We can't really define it by sex or ethnicity. I don't think that data is strong enough yet, but certainly if you've got features of the metabolic syndrome, you're at increased risk of coming to harm, and obviously if you've got histologically advanced disease. So these are the patients from a hepatology point of view we should be concentrating on. So what is actually the risk of developing cirrhosis or liver cancer or decompensation? And there really aren't very many good studies to answer this question. These studies come from either pools of patients that have had biopsies or the Olmsted County study. But it does illustrate the point that the longer you follow patients up, the greater the cumulative incidence of developing cirrhosis is. These studies do suffer a little bit of bias, and so these numbers may be somewhat inflated, but they're the best we have at the moment. These studies look at the incidence of cirrhosis depending on your baseline diagnosis, whether it's NASH or steatosis, and this just confirms that if you've got bland steatosis on your initial biopsy, your outcome is very good. What happens if you actually develop cirrhosis? What are your outcomes there? And this study comes from North America, and it looked at patients with NASH who had Child's A, B or C cirrhosis and compared them to hepatitis C patients. And you could see that if you have Child's A cirrhosis due to fatty liver disease, your risk of dying from your liver disease was actually better than if you had hepatitis C. However, if you actually decompensated to the point where you had Child's B or Child's C cirrhosis, your outcomes were equally dismal with median survivals of less than 2 years in some cases. How about hepatocellular carcinoma? What's the risk of developing HCC if you've got NASH cirrhosis? Again, the incidence is less than hepatitis C. However, in this cohort was still significant at 2.6% per year. And so hepatitis C is in the solid line and NASH cirrhosis is in the broken line. But you can see by 10 years, it's still nearly approaching a 40% cumulative incidence rates of HCC. And so given the significant burden of NASH in the community, the cumulative number of patients that we're going to be seeing with HCC due to NASH is likely to be increasing. Are there particular risk factors for developing liver cancer once you develop NASH cirrhosis? Principally, age is a consistent one. Metabolic factors such as diabetes also comes out. Interestingly, even though this cohort was said to have a diagnosis of fatty liver disease, if they'd had a remote history of excess alcohol or any alcohol, that was a significant cofactor. And in this Italian case control study, they found hepatic iron was a significant cofactor for the development of HCC as well. And this is also mirrored in the alcoholic liver disease literature. So if you decompensate or develop liver cancer, should you undergo transplant, and what are their survival outcomes like? This graph on the left demonstrates the cumulative percentage of liver transplant done for NASH in the United States. And you can see if you look at NASH and cryptogenic cirrhosis, or just a diagnosis of NASH, over the past decade, the percentage has clearly been increasing. In terms of etiology of liver disease, it's now the third commonest indication for transplant in the United States. And if we look at the ANZ data, you see a similar pattern. 3-year patient and graft survival are equivalent to other etiologies. So that's the liver-related complications of fatty liver disease. But recognising that fatty liver is almost an endocrinological complication, it's also been linked to the pathogenesis of diabetes. Now, why might that be so? I won't go into this slide in too much detail, but the liver is actually, aside from being the most important organ in the body, does produce a lot of pro-inflammatory cytokines and adipokines, which affect sites of insulin resistance, such as the skeletal muscle, as well as peripheral adipose tissue. And these pro-diabetic cytokines released by the liver have been clearly shown in animal model studies, at least, to increase insulin resistance and precipitate diabetes. And so there's good animal model evidence to suggest that fatty liver plays a role in the development of diabetes. And there's also some epidemiological evidence to support that as well. This is just a summary slide of the risk of developing diabetes in a number of large cohorts based on your ALT. So if you had a high ALT compared to a low ALT in these cohorts, your risk of developing diabetes was pretty uniformly increased about 2-fold. But ALT is not a fantastic marker for fatty liver. So if you look at ultrasound or imaging diagnosed fatty liver disease, as these groups have, and you control it for a number of potential confounding factors, you can see that the risk of developing diabetes, again, has been universally found to be increased in patients with non-alcoholic fatty liver disease. So it seems that there's reasonable basic and epidemiological evidence to support the notion that fatty liver is an important pathogenic step in the development of diabetes. Interestingly, if you have diabetes, your risk of dying from liver disease compared to the general population is actually higher than it is from dying from heart disease. And this has been shown in 2 cohorts from Italy and Japan. And so this comes back to the risk factors for development of cirrhosis and liver cancer in patients with NASH, profoundly centred around the presence of diabetes. And this is just reaffirming that fact. Not only is the risk compared to the general population of dying from liver disease greater in diabetics, fatty liver itself has also been found in one study at least to be associated with an increased mortality rate in a cohort of diabetics. This finding hasn't been replicated in other studies though. So the last part of my talk is really to look at the link between fatty liver disease and cardiovascular risk. And I guess this is in relevance to us when we assess these patients for transplant, because they obviously have a whole lot of metabolic or cardiometabolic risk factors. But if they have an etiological diagnosis of NASH, does that increase their cardiovascular risk further? And why might the liver influence cardiovascular risk? Well, again, the liver, aside from secreting a lot of cytokines and atherogenic mediators, it also is the thing that secretes your fats or your lipids. And when they've done studies to look at the lipid profiles in people with fatty liver disease, they are more atherogenic compared to patients controlled for other cardiovascular risk factors. And so there seems to be something specific about the lipid processing of the liver in fatty liver, which is pro-atherogenic. And so this is just a bit of data supporting that people with fatty liver have worse atherogenic cytokines, which they've just measured here. And you can see that not only is the atherogenic cytokines increased in patients that have NASH, it actually worsens the worse that your liver disease gets. So this is the stage of fibrosis in this cohort, and this is the levels of CRP and PAI1, or platelet activating inhibitor, PAI1 is pro-atherogenic cytokine. It clearly increases with the severity of your liver disease. And this is just showing, again, the thinking that as your liver disease increases in severity, your carotid intimal medial thickness, which is a subclinical marker of atherogenic risk, also increases. So patients that have got more advanced liver disease are likely to have more advanced cardiovascular disease or atherogenic disease as well. And this is some again, some epidemiological evidence to support that, showing that in these cohorts from the community or patients with type 2 diabetes, if they were followed up for about 5 years, if you had a presence of ultrasound diagnosed NASH or biopsy proven NASH at baseline, you had an increased risk of developing heart attacks or strokes after adjustment for a range of potential confounders. And this has also been confirmed in terms of cardiovascular mortality by this meta-analyses, whereas the previous studies were looking at incident cardiovascular events. When you look at death due to cardiovascular disease, fatty liver also appeared to be a risk factor. So this is just a bit of a summary slide of the natural history of fatty liver based upon the data that we have currently. And so if you take all comers with fatty liver disease, the current data would suggest that the incidence of cirrhosis over a 10-year period is maybe about 3 to 4%. The risk of decompensating over the next 10 years is probably about 45%, and the risk of liver cancer is about 2.5% per year. Once you do decompensate, however, in the presence of fatty liver disease, your prognosis is terrible, akin to any other liver disease. Now we know that if you've got a baseline diagnosis of steatosis, your risk is much reduced, and over a 20-year period, as high as 4%, but probably much closer to 0%. Whereas if you have NASH, the incidence of cirrhosis is higher, but really it's the baseline fibrosis stage that you have which determines your incidence of cirrhosis. Factors which increase the risk of progression from these stages: metabolic risk factors, diabetes and obesity, and for liver cancer, age, alcohol and hepcidin, and also cofactors. The problem we have is that clearly it's only a very small proportion of patients that develop end-stage liver disease with NAFLD, but we see a lot of patients in our clinics who are obese and diabetic with fatty liver who don't come to any harm from their liver disease, and so we need better prognostic markers for our patients. So just in summary, overall, cardiovascular and liver-related mortalities increased in certain subgroups of patients with NAFL. Those with underlying significant metabolic disease, and obviously those with fibrotic liver disease. NAFL appears to be a risk factor for the development of type 2 diabetes, and it increases the incidence of diabetes and maybe increases the mortality risk in diabetics as well. This sort of opens up a whole new paradigm of treatment for type 2 diabetes, perhaps targeted on liver and liver fat. And lastly, NAFL is associated with cardiovascular disease. Cardiovascular death is the commonest cause of death in patients with liver disease, but fatty liver disease itself appears to be an independent risk factor for the development of cardiovascular disease. And so when we see patients in our clinic, these are the things that we should also be screening for.